We're here with Brent Myers. He is Chief Medical Officer of ESO. It's a company that basically aggregates clinical data for first responders. Hi, Brent. Thanks for joining us.
Great to be here. Thanks for having me.
So walk me through a little background of what ESO does and how it connects hospitals and first responders.
Sure. Our company was founded in 2004 by a paramedic and a computer programmer, basically, who realized that the data being aggregated in the clinical care for EMS was really hard to share, both internally within an agency as well as externally to hospitals and other partners. And since that time, we have become one of the largest providers of data aggregation. So we provide an electronic medical record for firefighters and paramedics. And then we now aggregate that at the hospital side, not only for patient care in the emergency department, but for registries, repositories, research, and data across the United States.
So you recently released some interesting data that it's an interesting data dashboard on the COVID response and how it's impacting EMS and sort of what they're seeing. So I think what interested me the most about the data set was just that it kind of shows you what's actually happening versus like a projection. So I guess walk us through the data and kind of the big takeaways there.
Sure, great. And what we did back in March the 6th is that we added COVID primary impressions. And there's a technical reason that paramedics don't use the word diagnosis that's probably on this conversation. But for the purposes of analogy, it's like the paramedics diagnosis. We call it an impression at the federal level. And we gave the medics the ability to say, we are either suspicious that this is COVID, or this patient has already been tested and we know that they are COVID positive at the time of the encounter. So from there, we've been able to aggregate data around the care that these patients receive. And it is very consistent with some of the projections that we've seen around the country. And then it's also very consistent with data that we've seen internationally from China, Italy, and elsewhere, meaning that only about 10% of the patients that we encounter actually require EMS intervention. Most of them are actually quite stable and do very well. And then about 2 to 3% are critically ill across the country. Now, obviously in hotspots, that's not exactly the same, but if you're preparing as an EMS administrator to think about what do I need to respond in an average community across the United States, not in a particular hotspot, we're giving folks a lot of data about the clinical preparedness. So we think that's important. The other piece is obviously responders need personal protective equipment. And what we've learned, not unsurprisingly, is that they need personal protective equipment not only on calls that are highly suspicious for COVID, but because you don't know really until you interview the patient if they're at a high risk or not, you're having to wear personal protective equipment on many more responses than you did in the past. And indeed, in some communities where there's a high prevalence of disease, they're wearing personal protective equipment on every call. And obviously, hospitals need personal protective equipment, clinics need them as well. So we're trying to provide realistic data to help the federal policymakers understand how much EMS is going to need versus the other components of the healthcare system. So those are the kind of major things we're looking at.
Yeah, because most of the data to date is focused on the hospitals and the front lines there, not necessarily the EMS and the folks getting them to the hospitals, correct?
That's right. And we have worked with our federal partners and other partners within our industry, individuals that historically would be competitors of ours. We're now working together to aggregate these data to tell a consistent singular story about how much PPE responders are utilizing. And I think it's important even now at this stage to think about how often they're having to reuse personal protective equipment. In other words, it's not necessarily that they are completely out of personal protective equipment, but when they look at their projections, they realize that to conserve certain elements, we need to reuse. And there's a whole debate about how long one can do that and so forth. But our preliminary data shows that about a third of the time with the N95 mask that many people have seen on television and Governor Como and others speak about a third of the time our EMS providers are reusing a mask from prior in that day or prior in that shift rather than choosing to use a new one in an attempt to help preserve the supply for the next month or two or however long we may need them.
So your data set, how much of it is based on the actual, I guess the unstructured data from the 911 call?
So the great thing about EMS across the country is years ago, the national EMS data set was established. So there is a not free text, but structured data elements that are required for every EMS call. And those become more sophisticated with iterations. We're at version, depending on where you are in the country, 3.2 or 3.3 now. We're moving to 3.5 in the future. And each one of those iterations gives us better structured data that allows for more objective decision making. Because we are also the vendor of the software into which the paramedics and firefighters enter their data, we can control even beyond the NMSIS elements, the core elements, and bring those data in a structured manner. So what we are reviewing on our website and at the COVID Resource Center we put together is all structured data. We do have the capability with natural language processing and other ways to extract from the unstructured data that may be in the narrative where the medic's telling the story of the call, but it's a drop down menu where they choose their personal protective equipment or where they choose their medications or their critical interventions so that it's easily queryable and reproducible.
Okay. So over time, do you see, I guess, what do you see as more valuable? Is it that structured data set that's sort of, been created for a while, or will it be the unstructured over time?
The structured data is going to be much more important, and the beauty that we've learned here is how nimble you can actually be with adding structured data elements. Some of these we added to the software and deployed across the country within 24 hours of request. For example, the reuse. We had lots of requests so that the administrators could really determine how many new masks do I need to purchase. So we added those reuse elements in a very short period of time, but we also make it in an easy drop-down menu so that the medics have an easier time. Where interesting part comes is in the EMS to hospital interface. Historically, keeping that EMS record matched to a patient going through the ED so the emergency physician could have the data available about what happened in the out-of-hospital environment was very difficult. That is now also coming in a structured manner. But on the outbound data back to EMS to learn about outcomes, we're working through unstructured data in that manner. So getting more sophisticated about the outbound data back to the medic so they can learn what happened to their patient and improve. That's where we're really working that fine line between structured and unstructured, because the hospital language is just different than EMS, clearly.
Right. So the electronic health records and, the EMS data, are they interoperable these days? And I guess what's there now and what needs to evolve over time?
So great question. So historically, the hospitals were used to receiving a printed run record. And there was a period where, and this is just the facts of the case, where EMS would create an electronic record. It would then be printed, handed over to a unit clerk in the emergency department, only to be scanned back into the hospital medical record as a PDF, which
Ouch.
is kind of, that's just painful, right? And that was the most common way that this was occurring across the country. So the first step was, we're going to recreate the PDF and send it to you electronically. So at least we're not going through, paper and papyrus and all that step, right? And so that's what the hospitals were comfortable with. What we found over the past 2 to 3 years is the richness of the EMS data and the ability to predict how to care for things like sepsis, for example, where IV fluid resuscitation is so important. Know how much fluid was given by the medic helps the hospital determine how much additional IV fluid is needed. So now we're sending discrete data elements into the hospital medical record. So we know the temperature the medic obtained, the blood pressure, the medications that were provided, and we're receiving that back from the hospitals discreetly. So I would say there's some absolute best practices that are occurring now across the country where that is occurring. The ONC at CMS is really focused on this issue, and we just prior to the COVID outbreak, we had a summit in DC, a day-long summit around this exact issue, to move from kind of non-structured PDF type data in and out of the hospital, but to true discrete data elements. And we're making lots of progress in that way.
How are new technologies like 5G and those sort of things helping the data sharing between first responders and hospitals?
So two major ways that 5G is going to help us. The first of those is that when you have a lower bandwidth or in some cases a completely non-connected environment, obviously some of the data has to live at least temporarily on whatever device the medic is entering the data. And so when we want to push an update, such as the reuse drop-down menu, we have to wait on connectivity. And so our ability to be nimble and move quickly with updates pushing out to the field. And it also really has difficulty about which types of devices the medic can use. And, can you go all the way to a pure tablet device when we have to be able to store some of the data in a non-connected environment? So 5G helps with that tremendously. The other piece that we're really excited about is the telemedicine component, so that there's enough bandwidth, if you will, to share things like an EKG tracing in real time or an ultrasound in real time, and for the physician to be able to do an exam on for example, a stroke patient in a remote manner to determine the best hospital destination for that patient. And the ability to do that without worrying about bandwidth and all of that is going to be tremendous for us.
So if we play this out, 5G covers every place, rolls out a lot more. You could literally have an EMS worker and then a doctor on a video call in the ambulance before they even get to the ER?
Absolutely. And as a matter of fact, there's a federal program now that they were supposed to roll out in 2 or 3 months. It's probably going to push because of COVID, but it's called ET3, and it's an innovation project from CMS. And the notion there is that we are definitely going to support the medic, not only in the acute patient that's coming in that may help prepare for stroke or trauma or that type of thing, but also for the very low acuity patient. You can also have a telemedicine visit and perhaps avoid the transport altogether. So it's kind of both ends of the spectrum. That telemedicine piece is really important.
Okay. As this evolves, how do you think the COVID pandemic will impact? I guess how do you think it will impact data sharing overall? I mean, I've been collecting some of these data sets and visualizations and it's really nice to see all the data sharing and, I guess we're all data scientists at this point. How do you think the pandemic changes, not only the data sharing in your neck of the woods, but also across the health profession overall?
I think that, the fundamental of never waste a crisis, this is one of those opportunities to demonstrate that the concerns about privacy are very important, and we can never forget those, right? I mean, this is personal health information. We have to have the security. We have to make sure that whoever's looking on the other side has a reason to look and all of those things. I think, however, the pendulum historically has swung a little too far, and we've been overly concerned about things that, quite frankly, patients would be perfectly happy that we would share. In other words, if sharing data in aggregate in a de-identified manner, so that we're not individually identifying a patient, but we can say in this community, we are 6 days away from trouble, and it may not be COVID, it may be whatever it is. The ability to plan at that level, at the macro level, and not be surprised is I think where we will land on the other side of this. And again, I'm not downplaying the importance of HIPAA and all the needs to protect a patient, but there are ways to share the data that don't violate that and that protect the patient's identity, but that allow people at the local, regional, and even national level to be much better prepared going forward. So that's where I think we'll be. And the ultimate goal of that would be for that medic at the bedside to have decision support to say, I have a patient with the following illness. Where is the best place? And does that best place have a bed for me now? And if so, what's the best way to get my patient there? Is it by air, by ground? All of those options that could be in the hand of the medic at the EMS level. And then the same thing at a clinic, an urgent care. It could go across the healthcare system to do that bedside decision support.
Okay. Any final points to add that I didn't ask?
The most important thing here is, I think, using these data allow us from the EMS and out of hospital perspective to appropriately make requests during this current outbreak. We don't want to be the ones that say we have to have every piece of personal protective equipment, because obviously our colleagues in the hospital and elsewhere need those. but the ability to appropriately make requests and appropriately plan as our slice of the healthcare continuum, I think is very important in the near term. And then to your point, the far term is getting much better.
All right. Thanks for joining us.
Thank you.